Okay, we're live, and today's Wednesday, and I'd like to welcome everybody to our Wednesday Facebook Live, and we're also on Instagram Live. And I was trying to figure out what topic to talk about this week, and I thought I'd speak about incidental liver lesions. I gave a talk at a meeting this past week speaking about cystic hepatic masses and solid hepatic masses, and I spoke also about incidental hepatic lesions and how you deal with them. And there's been a recent article, ACR recommendations, and so I thought I would do that as a starting point. So let's get started. And there's an article by Richard Gore from Northwestern. This is a number of years ago, about 6 years ago. Managing incidental liver lesions depends on the probable importance of the mass. Importance is assessed based on the appearance of the mass and the level of risk for each patient. And that's a very good way of thinking about it, because at the end of the day, the reality is that most of the liver lesions we see are going to be benign. Remember, we speak about how 10% or more of patients have incidental hepatic cysts. We talk about how 7 to 10% of patients have hemangiomas, others have hamartomas. So it's really going to be something that will indeed be very common. So it's important to figure out what you need to do in that scenario. There's been, in that same article, Gore also makes the point that even in oncology patients, up to 52% of the lesions are going to be benign. So even in patients who have a high risk, you're going to have the same issue, that most lesions are going to be benign. So the challenge is, how do you know when to deal with a lesion? When do you need to work it up? When do you need to biopsy it? Are there certain criteria you can use to make all of this happen? So I think that indeed becomes very, very important. And when you start looking at the ACR looked at this when they spoke about incidentalomas a number of years ago, and spoke also about the complexity of evaluating hepatic masses. And in fact, the ACR has charts for these things. And the chart actually was somewhat complicated. You can see it divided things up into a number of different categories, including lesion size, and perhaps that was the first breaking point. And then you can see there's a lot of places to look here. And usually I have this feeling if it's too many boxes, it's going to be somewhat difficult. Well, the good news is on the newest ACR, and this was headed by Gore, there are the boxes. And you can see it's very unusual. We went from more boxes to less boxes. And when you see on this list, you can see the way things are divided. If you look at it very closely, it's less than a centimeter, 1 centimeter to 1.5 centimeters, and then greater than 1.5. And you can see that one of the things this article does focus on is that the lesions under a centimeter, either they're benign or likely benign, and even in a high-risk patient, you might decide to get a follow-up in the short term, perhaps an MR. But when lesions get larger, particularly over 1.5 cm, then you're more aggressive in the short term. This article also makes the point that you can see under each category that if it has benign imaging features, so we always speak about how things look like signatures, hemangiomas, hamartomas, FNH, and the like, so you can really fill things in. The article also focuses on risk. Somebody, a post-trauma case, a patient who's a renal donor, things like that, vague abdominal pain, the risk compared to a patient who has a known sarcoma or colon cancer is significantly different. Once patients have cancer, there's a more likely chance that the lesion you see is of concern. And also, if it is of concern, and it really is metastasis, that may result in changing therapy. So it's very, very important that you have this idea of how to manage things. And this works pretty well. And I'll show you the article. I was part of that article. And again, it's a typical ACR criteria where, again, you're trying to reach some sort of consensus using both the science as well as people's experience. And I think the article is well done. And let me just go through a couple of the major points within the article that I think perhaps are going to be helpful. So the article does make the point that really what are we trying to accomplish? Consensus is always hard, but we're trying to develop a consensus on patient characteristics and imaging features that are required to characterize an incidental finding. That's one. Number two is we're trying to provide guidance to manage such findings in ways that balance the risk and benefits to patients. Simply biopsying everybody would not be a good strategy. Simply following everybody would not be a good strategy. Number three, recommend reporting terms that reflect the level of confidence regarding a finding. And that's something we do all the time. Clinicians need to know if we're suspicious, if we think it's probably benign, if we think it's probably malignant, what do we recommend? And finally, focus future research by proposing a generalizable management framework across practice settings. And again, one of the things with the ACR guidelines, of course, it not only reflects what needs to be done in places like Hopkins, but also a small community hospital 5 miles away. So again, trying to balance all of those things. Now, when you look at some of the basic factors, one of the things about this algorithm, it's basically focusing on asymptomatic adult patients where CT was not requested for a liver lesion. The algorithm is designed for use in patients with variable risk levels, low versus high, as we mentioned. However, the algorithm should not be applied when the index CT was requested to evaluate a suspected liver lesion or hepatic abnormality. That really is the point. If someone's being evaluated for hepatoma, this is not when you're using the criteria. These are incidental findings. Patients where you see findings that are suspicious malignancy, this is not the case we're talking about. We're talking about purely incidental findings. So that becomes very important. Now, in this article, they do also mention that there are several things you need to look at. And this is a good list because it's a list that we see with any patient. Lesion size, attenuation, homogeneous versus complex, enhancement pattern. Think peripheral puddling, think hemangioma. Think filling in with central scar, as bright as the IVC, think FNH. Dense rim-like enhancement, think metastatic disease. Lesion margin, again, cysts are well-defined, malignancies typically or commonly are infiltrated. Multiplicity, that can be helpful, but we know that cysts, hemangiomas, FNH, hepatic adenomas, metastasis, all can be multiple. Lesion growth pattern, something doesn't change over 5 years, it's benign. Or it's a hemangioma and it's benign. But if something is doubling over 3 months, you have to worry it's malignancy. Now, it's not always a malignancy. It could be an abscess, perhaps, but it's something you worry about. And, of course, lesion location can be helpful. It's more saying that some lesions, particularly pseudo-lesions, are more common in certain locations. For example, focal fatty infiltration is very common near the falciform ligament. So location can help you at least think about the possibility that you're dealing with a pseudo-lesion rather than a true lesion. And now if we go back to the chart we started with, you can see when you look at the chart carefully, and let's just not spend too much time, but I think you ought to print the chart out. You go to the ACR website, and you can see the big categories under 1 cm, 1 to 1.5, or over 1.5. And then within that breakup, there are different categories. And again, over 1.5 is the ones you worry most about. Of course, if it has a benign imaging feature, you can stop. But if it's suspicious, then you need to go. And depending on whether it's low risk or high risk, depending on whether the patient has a known or suspected malignancy, that's really what you will be determining. Obviously, a lesion in a high-risk patient, which looks worrisome, you're going to go and do a biopsy. Just doing another imaging study is not going to help. So again, this is really a very nice way of thinking about the process. So let's look at some of the comments from this article that I thought would be helpful, and let me focus on. I mentioned this a moment ago about why location is important, because specific regions of the liver are susceptible to perfusion changes or fatty infiltration or sparing, and these can mimic disease. Peripherally so-called THADs or THIDs reflect changes in enhancement of the parenchyma due to relative differences in hepatic arterial versus venous supply. Near the falciform ligament and gallbladder fossa, alterations in venous drainage can result in focal fatty deposition or sparing. So again, just be aware in certain areas, don't overcall, don't fall into that trap. You need to know that factor, and that indeed becomes very important. And then, again, a low-risk patient, which means someone you're scanning for trauma, someone you want to, you're scanning because of vague abdominal pain, the patient's 30 years old. Incidental liver lesions that's less than a centimeter do not require further workup and can be considered benign. Incidental liver lesions that are 1 to 1.5 cm and have benign or flash-filling features also do not require further workup. Prompt MR is advised for lesions with suspicious features that are 1 to 1.5 cm or greater. And that's kind of what I said before, and that's what the chart that shows, and I'm just reviewing that. Another factor, something else to consider, is that in high-risk patients with incidental liver lesions under a centimeter, MRI is advised in 3 to 6 months. For lesions that are 1 to 1.5 and have benign features, no further workup with MR is necessary. For lesions of this size with suspicious or flash-filling characteristics, we recommend MR. So again, even in the oncology patient, if it's under a cm and it looks benign, stop. If you're uncertain, come back in 3 to 6 months. That strategy seems to work very nicely. And the article put some take-home points at the end, and I thought I'd review this with you again just to focus on them. 1, Forgo workup of incidental hepatic lesions under a centimeter in low-risk patients. Forgo workup of incidental hepatic lesions with distinctly benign features regardless of the risk level. A hemangioma is a hemangioma, being in a non-malignancy known patient or patient with a known malignancy. Pursue workup of incidental hepatic lesions over 1 cm without distinctly benign features, especially in high-risk patients. So that's kind of a very nice way of thinking about it. And again, it's a very good strategy that's probably reasonable to follow. So perhaps as you're getting started, you could print out this chart and take a look at it every once in a while. I think this goes back to some of the value ACR committees do have in these ACR criteria. It gives you a working method of evaluating patients. You don't want to be doing something different for every patient that comes across your desk, and you don't want everybody in your group to be doing things that are different. So you want to be very, very careful with that. Now, let me look at some of the questions we have. Someone mentioned, what about patients with hepatitis C? Well, if you have a patient with hepatitis, they're not a low-risk patient because you're always going to worry about the patient developing hepatoma. So when I look at a patient with hepatitis C, I'm especially concerned for even the most subtle of findings. If you see a vascular lesion, 8 millimeters, I have to worry about a hepatoma. You know, when we talk about simply following patients with small lesions, those are these incidental lesions with a high likelihood as they're benign. With a patient with cirrhosis, there are still many benign lesions, but you have to worry about the possibility of hepatoma, and so those lesions are managed more aggressively. Let's see what else. I see a few people want to know how I am. We're doing fine. We survived the RSNA, and we see we have friends from Berlin and Edinburgh, Texas, and Reno, Nevada. But what I'm looking for is questions. So if you have any questions, we got a couple minutes left. This is the time to ask it. But I will again make the point that patients with hepatitis B, hepatitis C, patients with prior malignancies, these are not the patients who really we're considering in this algorithm. It's really focusing on the incidental hepatic lesion and then going from there. As I mentioned, if you have a patient where hepatitis just makes it likely for hepatoma, and the hepatomas are often small, if you're uncertain on CT what's going on, I would go to MR. That's a very logical way of doing things. And again, you want to look at that risk reward, so that indeed becomes very important. So I think this will be very helpful. Hopefully it gave you some more information than you had to begin with, and hopefully it provides a way of thinking about hepatic lesions that perhaps you've had a problem with. I think it's always a challenge for all of us when you see those small lesions. a 5 millimeter incidental lesion, whether it's in a malignant patient with a known malignancy or just an incidental finding in a patient without malignancy, you always wonder, do you say advised clinical correlation? Well, everybody hates the term advised clinical correlation. Nobody wants an advised clinical correlation. The referring docs hate it. So this strategy gets around advised clinical correlation and says small lesions under a sonometer, simply follow, repeat the study. So with that, I think I'm out of questions.
I'll post the chart to Instagram.
Wait, we got the Instagram questions?
No, I'll post this chart to Instagram when we're off.
Okay, we'll post the chart to Instagram. I see a lot of people are on Instagram. I don't think we can answer questions from Instagram, but we can. I can see a lot of people. Wow, a lot of people like Instagram. Okay, we'll have to figure out there's a better way of doing things on Instagram. There's actually more people on Instagram than there is on the Facebook Live. But well, maybe we'll try to figure out a way if we can get questions from people with on Instagram next time. And we are doing a lot of work on Instagram. I think we have over 5,000 followers. It grows on a weekly basis, and I think we're putting up some terrific things. And with that, we'll see you next time. Bye.